Okay.
We good to go? There we go.
Yeah.
Hi, everybody. Welcome to Tuesday Tea. We are very happy to have Patrick Monette here with us. And Patrick is an EMDRIA approved consultant as well as a consultant with the Institute for Creative Mindfulness. Patrick's in your northern New York State, correct?
Correct.
Okay. Up by all the lakes, I hope. In addition, Patrick's a certified life coach and works a great deal with couples and with anger and with addiction. And we are very excited to have Patrick on as a new member of our instructor team at the Touchstone Institute. So, Patrick, I'll hand it over to you so you can tell everyone a little bit about your course coming up on October 4th.
Okay, awesome. Well, thank you once again for inviting me. I'm so excited to be with you today and spend time with some amazing people. It always just brightens my day. So it's so good to see you all. And taking me the opportunity to be here and connect is always, I always value it. So on October 4th, we're offering a all-day anger management course. And the name, because jumping is I'm not angry, which I just thought was a funny way to do it, of exploring anger management and EMDR through the perinatal lens. And what we were just talking about before we went live is, even though the title and a large focus of it will be for people who work in the perinatal lens, perinatal field, it's really for any EMDR therapist who has any desire or need to really understand the role of anger in trauma and mental health. Now, one of the components that I love to do is also being able to have the conversation as a clinician. What is our relationship with anger? How are we seeing it clinically? And how do we address it in a trauma-informed AIP model approach to help our clients? I try to make it very interactive. I think we've all been to those courses that are a whole day is long, so we try to make it interactive, so that way when you leave, you're not only energized, but you have a plan of how do I want to go forward, not only when with an increased insight of ourselves as people, but also how we can incorporate the education and the approaches into our clinical practice.
Thank you, Patrick. We're so excited to have this course launching. I feel like I've been talking to you for years about anger, and I don't have any it's just such a useful topic to cover, and I think one that's so often looked over, except outside sort of like really specific examples of what anger looks like around
Yes.
rage and explosiveness and all of these things. I'd be curious just to hear sort of how did you get into this specialty area?
Well, if we're gonna spill the tea on Tuesday Tea, right, and keep it real, it's because I lived it. I know what it's like.
Yeah.
And the reason I say that is, and I just kind of am going to jump to something you said, is the the first piece of any knowledge about anger. It's not just aggressive, violent anger. Anger, what we go over in the course, is really, the way I explain it, is like a spectrum. There's different ways to do it. We have passive, passive aggressive, aggressive, and what we want to get to is assertive behaviors. And my experience with anger wasn't the aggressive violent. It was much more of growing up, learning. It would fall under the category of passive aggressive, using the backhanded comments. That's what I was exposed to, right? And what I saw in my culture, and in what I was really exposed to growing up, in and outside of the family, I think would be a fair assessment. More in I'm just thinking like work environments, especially in school. There was a lot of passive aggressiveness. And so I learned how to master it. And I learned how to become that passive aggressive, unfortunately, really angry individual. And it was painful to go through, because then when you start your journey of healing those issues, you start seeing that it's really not about anger at all. But you have to acknowledge and honor that the anger is there, instead of just trying to pray it away. And I say that because I was raised Catholic, not to be offensive, but that was like a lot of the answers. Like, if you were good enough, if you were strong enough, if your faith was good enough, but it didn't help with my pain. It didn't help with the experiences that I was having as a young man and how it affected me growing into a young adulthood. And when I went into grad school, one of my practicum projects was actually one of the biggest projects I was given was to revamp an anger management group for adolescents. And it's one of those things, one of those opportunities that when you're doing something, you're doing it for someone else, but you're also seeing yourself. And so you get to sort of that vicarious healing as well of this is what I needed when I was that age. I can relate to this. I can see this. And it also helped me to see areas where I've grown and healed, but also things that I wanted to develop aspects of myself that I wanted to incorporate in the training that I didn't have at all. And being able to offer anger management, I did it with a co-therapist I was the intern and she was the full-time therapist. It was probably one of the best groups that I've ever experienced. The most educational, the most empowering, and learning about myself and what people go through when we're talking about anger and anger management, and also some of the privilege that we talk about in the mental health field that I don't think we address ever, about feelings, about talking, that everyone's just supposed to be in touch with their feelings. And also how to have a healthier relationship with anger and not fear it. Oh, I can't hear you, Chuck.
Chuck, I think you're muted.
Oh, there we go.
I did the double click. I think that that noticing and not ignoring it piece is so important, not just for the client, but also for the clinician, I imagine, right? So I'd be curious to hear sort of like, I know you do consultation obviously with clinicians. Like, what are some of the common sort of questions or roadblocks you see clinicians running into around how they're like addressing anger head on in their clinical practice?
Yeah, that's a really great question, and we actually go over this in depth in the course that I'm really excited to
Cool.
on the fourth. Uh, w- One of the first questions that I ask is, how do you deal with anger? Because I can't guide someone and support them if I don't know how you define anger as a person, especially as a clinician. What is your experience with anger? And that comes from my own experience of after I entered the field and I was running groups and I became like the anger management guy almost everywhere that I worked. It just became a group that I really enjoyed. Uh, it was always fun, educational, and really powerful. It was
Mm.
sort of like those groups became sort of like the island of misfit toys, where these people from all the different backgrounds would come, but they all knew what it was like to be really ticked off, or or they had no idea how to deal with those intense emotions, and they were just sort of thrown because they were the angry ones. But the groups we actually extended it. It's like 8 weeks is enough, then we do 10 weeks and then 12 weeks, and then I'd offer it again and they would be taking it over and over again because we had a connection, right? Like I tried to be very real, and normalize that what they were going through wasn't, maybe some of their actions could have been tweaked a bit, but we all learn. But what I was seeing was a lot of judgment and stigma towards them in the working environment, which really disturbed me and upset me, because I would hear clinicians say, "Oh, well, here's another angry one for you," or, "Oh, this one's an angry one. I don't want to deal anything with it," or, "I don't like the angry ones," as if there was some sort of like diseased,
Yeah.
stigma about it. And so part of that is I incorporated that into the training of when I'm working with with a professional. I need to know, what is your relationship with anger? And it's not ever to be judgmental, it's never to be harsh, it's to be real and genuine. So when we're doing a basic training for EMDR, one of the guidelines is, don't work with populations you may not be working with just because you're learning EMDR. And even though EMDR is extremely effective with anger and anger related issues, you have to have some training and understand what anger is and what it's doing before you go in and start applying EMDR to it. And so the further along I got in my fields, in the fields in my career, and when I finally got trained in EMDR, it was sort of one of those opportunities of, how can I incorporate the AIP model into group therapy, right? Because it wasn't really, and this was way before COVID, so telehealth and all those different things weren't really, as accessible as they are today. So I sort of created it as I went, and I just started incorporating some of the resources. Sorry, I feel like I'm jumping around to your question. Let me
No, it's
reframe.
great.
Is that okay? Okay, sorry. I just started talking. You know me, Chuck. Just like pull the plug if I'm going too much.
Don't
Um,
stop the flow. You got all the
uh,
good things to say.
but all of those things, it taught me. I think you hear this from most EMDR trained clinicians where they say, "What was I doing before EMDR?"
Totally.
And when we're looking at anger management, I feel that I did the best I could with what I had. I feel like I did a good job offering that and addressing it and treating it. But understanding what trauma really is, understanding the AIP model, helping people learn how to have a healthy relationship with their anger instead of demonize it was
Mhm.
revolutionary for my practice. And it was also revolutionary for me as a clinician because I'm a human being. And one of the things we were talking about before we went live was anger is part of the human experience, and there's this push in so many fields to just not be angry, to get rid of anger, to just shut the angry off, to bypass the anger. And going back to your original question is, so that's what I want to know when I'm working with a consultee of what is your relationship with anger? How do you experience it? What is your, because if they have a healthy understanding of it, or if they've been exposed to negative experiences with anger, I can work with them. I can help them to be able to in a healthy way separate that from their personal needs and what we can address of how I can support them in that and how to address their clients. Because in some
Yeah,
cases we can't choose who we work with, right? But we want to do the best care.
absolutely. Yeah, and I love that, like, situating within the practitioner to start, right? Of like, if they don't understand their own relationship to anger, right? And we all have a relationship to anger, whether like we experience anger a lot or not, right? Like we interact with other people experiencing anger. Like, I think that is such a important step that is often missed, right? Of like the way that the lens you're seeing your client's anger through is so dictated by your own experience and relationship to it.
Right. And when you're working with people who've experienced trauma, abandonment, neglect, abuse, all of the things that we see, someone has to tell them it's okay to be angry. Part of the healing, they
Absolutely.
have to be able to, and that is what is so beautiful of it because that can look like such different things. It can be turning it into a target. It can be using resourcing on it. It can be just having a conversation about it. It can just be expressing the fact that they were angry. And and really exploring how that anger manifests in their life, because
Absolutely.
then we're going to know I don't want to just throw empty coping skills at someone. I want to be deliberate in what I'm doing to help them. This is kind of how I present EMDR to new clients of, I want you to be able to take care of yourself without me. And they look at me a little strangely, and, and then I use a very specific US based analogy. It's like, I want you to be able to go to Black Friday shopping and to be able to handle your anger and your panic attacks and be able to get that gift that you need on sale at midnight. And they look at me, but they know exactly what I'm talking about if they're from the US, because that shopping, if you're not from the US, it's a very intense shopping experience, which can create trauma on its own.
Mm,
But they know what I'm talking about. I want you to be able
absolutely.
to, and that's where EMDR comes in. Is it may not be perfect, but I want you to be able to go to that reunion at work, or that meeting at work, that family reunion, that holiday that's
Mm,
coming up, and to be able to notice your emotional reactions, and to be able to take care of yourself with evidence based, tried and true coping skills.
absolutely. I love that. Do you have, Patrick, sort of techniques, on the therapist end of things, like to help therapists get less afraid of anger in their clinical practice, whether that's in themselves or in their client?
I think that's all individualized because what I see, I can just think of one person, it was a good friend of mine, a colleague, and they had a really strong aversion to anything related to anger. And the more that I learned about anger, the more I learned about trauma, I was able to put the pieces together. And then when you get to know someone a little bit of, oh, they've experienced violence.
Mhm.
And without saying it, I was able to put the pieces together. And then when you do something after for so long, for so many years, you see warning signs of, okay, this person has been exposed to really destructive anger. It
Mm.
made sense to me why they're having that reaction, that it wasn't either comfortable, safe. It didn't feel like it wasn't an area they wanted to work on. There's really a limitation of what I can do. I can recommend individual therapy. We can talk about it because I don't want to cross that line, especially in consultation, of what
Absolutely.
consultation is and into therapy. But being able to go into that of hopefully normalizing it a bit. I don't want to invalidate and just say, oh, anger is great. We should all just be like the Care Bears and just talk about it. It's like, because sometimes it isn't safe, right? Like I've been in clinical situations working in addictions where if someone's under the influence, their anger could be violent. Like if substances are involved, or if certain things, like we talk about this in grad school. We want to make sure that we're safe. We want to make sure that if a client ever becomes dangerous, we have a protocol in the practice. But that is more of a rarity in my experience. And I think what I see in my clinical experience is when people can't handle conflict, when people can't handle a client or someone being upset with them. That, I mean, because we're saying, come to us, we'll help you with your trauma, we'll help you with your mental health issues, we'll help you with your addiction issues, just as long as you don't get really angry, or you don't swear, or you yell, all of these different silent stipulations. uh, we have to find a way where we're feeling safe in our working environment, but also emotionally, of I'm not going to be afraid of someone being angry with me, just like I'm not going to be afraid of someone crying. It's an expression. They need to get it out. I always say better out than in. And I'm also, in my practice, from day one, I'm incorporating the AIP model. I'm starting to teach them, whether someone comes to me specifically for EMDR or not, I am
Mhm.
teaching them resources. I specifically, this is my practice, EMDR resources, because they work.
Absolutely. Patrick, will you just, for anybody who's watching this who isn't an EMDR practitioner, can you just talk a little bit about the AIP model?
Sure. So it's the adaptive informational processing, and being able to look, what we're talking about with EMDR is exploring how to identify and address traumatic or problematic experiences that the person has had. And normally what we're looking at is how to identify what we call the negative belief. And the negative belief, or the negative cognition, is what the person believes about themselves relating to the problematic event. So let's say it was a traumatic event when they were little. Most people will say, well, it's the traumatic event that's the problem. But really, what is holding it in place is the negative belief we hold about ourselves. Like, I'm unworthy, I'm at fault, I'm a piece of crap. There's some sort of negative cognition that acts as cement into the brain, or really, really strong glue, depending what analogy you want to go with, that holds that trauma in place. That's why, for example, so many people struggle, like that when we talk about flashbacks. Or one of my favorite examples is, has anyone, like if I'm doing group therapy or group experiences, has anyone ever had a bad breakup? Right? And everyone just was like, yeah, blah, 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 and you start a little bit of the conversation, because that's one thing we can relate to. And I'll say, what would it be like if you went to the grocery store and you saw your ex? And we talk about that. It's like, well, I'd probably get really angry. I'd start sweating. I'd get really scared, depending on the relationship. And then I asked, what would it be like if that person said hello to you? It would throw you, right? Because you've had this whole monologue, you've had this whole scenario of who this person is, and they have moved on. Whether good or bad or in between, they've moved on, right? So even though we may have plotted awful things happening to them in a million different ways, they just said hello to me. I've been plotting my revenge for so long because I would, whatever that might be. And sometimes people get really stuck on that, and that's a really mild experience. But when we can't work through something on our own, when other types of therapies haven't really gotten to the nucleus of that problem, the AIP model with EMDR really helps identifying and helping the brain to process those disturbing and upsetting experiences, and then getting it to a place, really through bilateral stimulation or dual attention stimuli, to help the brain communicate more efficiently, to be able to be more receptive to adaptive information. So if someone's not familiar with EMDR, I use this example once with a college student when we're talking about the brain stuff. And I said, at the end of the semester, when your fridge is filled with ramen noodles and moldy cheese and expired milk, they're like, well, yeah, that's the end of the semester. I said,
Obviously, yeah.
I said, what would it be like when mom and dad come and take you grocery shopping? And then all of a sudden, you have all this food again. I'd be like, that's amazing. That would be great. I could eat again. I wouldn't have to order out cold pizza. Said, what if we could do that in your brain? What if we could get rid of the stuff that you don't need anymore and replace it with love based, adaptive, positive, strength based belief systems? What would that be like? And that's what we do with EMDR. We don't make anything go away. We can't make traumas be undone, but we can give you a path to explore it so the pain doesn't have to weigh you down anymore. And I have people who, for example, in conversations, will say, "Well, I'm over it. That's done, and I don't need to talk about it." Well, that's the nice thing about EMDR. We don't have to talk about much. I can do a lot with a little. And then, as you notice, I tend to use a lot of food analogies. I'll ask the person if they say that to me. It's like, well, it's fine. I'll say, have you ever picked up a sack of potatoes? And they'll say, well, yes. And I'll say, what would it be like if you never put that sack of potatoes down? If you had to carry it with you for the rest of your life, what would that experience be like? I would probably get really tired. It would weigh me down. I wouldn't have the same stamina. And I said, exactly. And now what we're going to do is add a sack of potatoes for every disturbing, traumatic experience that you have. And then I'm going to ask you to run a marathon. How are you going to respond to that? Well, I may not be able to run as best as I could if I didn't have the potatoes. Exactly. When we have that emotional baggage, when we have that trauma, that pain, and we don't have the capability of processing it, it's going to weigh us down, and it's going to prevent us from living the life that we should have been living without the trauma.
Mm.
And when I'm working with someone, whether in the EMDR world, we use the term resourcing for every therapy. It's coping skills that are based in EMDR, and being able to help clients work through those moments of disturbance is really empowering, because the more they do it, the more they practice it, the more that they learn that not only, wait a minute, it works, I feel better, that's odd, I can actually start making better decisions for myself instead of reacting.
Absolutely.
Is that helpful?
Super helpful. Thank you. And I imagine for clients, right, who like are carrying around all those sacks of potatoes, like anger is just such a reasonable response to that, right? Like you're
Right.
seeing other people running marathons without any sacks of potatoes and thinking that would be easier to do, right? Like, why am I carrying all of this around? I know there's so many different forms of anger and so many different reasons, but I imagine there's liberation for people just in realizing that, like, right, your anger is related to these things that you're holding on to,
Right.
and that like we have tools to offer you to help you put the bag down.
Right. And going back to your question, Chuck, too, of if we're talking about clinicians for a minute here, if you've worked in a clinical setting, you have every right to be angry at times, right? And the
Totally.
more the more I hear, of client cases, case management, caseloads, documentation, dealing with insurance companies, no shows, um, y- you know, lack of pay raise, all of the things that clinicians deal with on top of their clinical issues, right? And not being able to let that anger out because they need the job. You
So
know,
do
Absolutely.
you have specific advice when you have a consultee who's learning how to work with clients who are experiencing anger, um, how to deal with their own?
it's a really good question, and I'm just processing how the best response is. Well, the first thing I normally say is, yeah, you have every right to be angry. Like,
Yeah.
let's just like validate this, okay? Like, you have every right to be angry. Let's figure out what you're doing with it. And then the other piece too that's really important, what's happening besides the anger? And I know that in the therapy world we talk about, primary reaction, that's a secondary emotion, as if it doesn't matter. It's like I don't care what primary, secondary color we're dealing with. It's still real. But if we don't go into some of those more vulnerable emotions, we're never going to find relief.
Mm.
And being able to have that conversation of, so when your boss talked to you that way, or when your supervisor said no, you couldn't do EMDR because you're too new, or oh, it's a new therapy, all the nonsense that we probably hear, right? That we have to guide people on. What else are you feeling? So you're feeling angry. Are you feeling disrespected? Are you feeling sad? Are you feeling disappointed that you can't do what you want to do, or you can't move, or you have these limitations? Let's unpack some of those other emotions and give them a space at the table.
Mm.
And then not only what that will do is it will hopefully create a secure space for those other emotions. You're going to see the angry piece is not going to have to shout as loud. When I'm talking, and going back to your question, Mindy, is a lot of times people will say, "Well, how do I just get rid of the anger? How do I just shut it up? I just want to cut it off." I'm like, okay, well, that's an option, right? And then um, healthy emotions, all about balance. I'll ask them if they ever have seen a toddler cry, and they say, well, yeah, and I'll say, what do you do when that toddler's crying? Well, I comfort them. I try to see what's wrong. I pick them up. And well, here's two things that I do. I'll say, and you rock them, right? And then they start feeling better. You're doing bilateral stimulation so their brain can process it and then they calm down. You're also honoring them, experiencing them, seeing them. They don't care that the boogeyman's not real. They want to know that you're going to keep them safe. As
Mhm.
adults, we need the same conversations. So that anger part
Mm.
of me is it's okay that I'm angry. It's not okay
Yeah.
that I break things. It's not okay that I'm inappropriate. It's not okay that I do destructive things in my anger or suppress it. But we want to create the platform to be able to say how I am angry and I'm feeling these other things. What do I want to do about it?
I
And
love that, Patrick.
is that helpful a little bit?
Immensely
Yes,
helpful.
I
And I
think
think just, yeah, like you removing the hierarchy of, right? I think that like secondary emotion thing is so commonly used in therapeutic settings of like, you're angry, but like, what's it really about? Right. And it's like, I'm
Right.
angry. And also, I think is like
Yes.
so much more helpful and so much more stigma fighting, right? To say, like, your anger gets to take up space in this room. We're not going to like pretend it's not important because it maybe is related to something else.
Right. And we're not going to make you feel like you're doing something wrong. We're going to adjust if there's inappropriate behaviors. We're going to address that, and sometimes with anger management groups, it tends to be more of the demonstrative, destructive energies. But over the years, I've actually gotten more and more people who want to know about passive and passive aggressiveness because we're
Mm.
seeing more and more and more of that. And we also see that it's usually in the family, which is always a fun conversation of, so how was one of my favorite when I'm working with couples, one of my favorite questions is, how was anger demonstrated growing up, and how was conflict resolved growing up? And then normally I ask them, have you ever had these conversations? And in some cases they've had those, But the majority of people have never talked about this with their partner. And then
Interesting.
you're in a committed relationship and you're wondering why you can't resolve anything when you're speaking different languages.
I love that. Yeah. Right. Really helpful to think of it as different languages because there's so much right around anger and especially like passive anger where it's so much around like body language and intonation and all of these things that maybe aren't about direct communication in the same way.
So, do you find that people have a difficult time recognizing more passive anger as anger? Because I know, like, just I've had conversations like that, like, not in a therapeutic setting, but where it doesn't look like what you think of when you think of anger. I'm just curious if
Well, there's a lovely course on October
that's true.
4th
Yes.
where we will go into even more depth because I love that question. But what I can say is one aspect I've noticed in the mental health field is clients are rarely asked how they deal with anger because they're presenting with other symptomology. It's trauma,
Mhm.
it's bipolar disorder, it's ADHD, it's depression, it's anxiety, it's all of these other things, and we fall into that pattern of, okay, oh, this anxiety or this depression or this blah 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 blah. I have the protocol for that. I know what to do. How do you deal with anger? And it's not just a one question, it's a conversation. And it's interesting how people respond to that. And some people actually get really offended,
Yeah,
right?
I was just to follow up with you. Read my mind.
Yeah, just like because passive people, how do I say that? I'm amazed at how many people believe they're above being angry. And when I personally and professionally talk about being angry, face a lot of judgment. That something's wrong with me because I'm talking about being angry.
Mhm. Right, just
And
acknowledging it.
right. And to me, that's not my side of the street. That's not my responsibility to do their work. It just shows me, okay, so I know that this may not be a safe person to talk to, but it just reassures me that I'm doing the work that I'm supposed to be doing to help people and to have the conversations. Because if you're uncomfortable with my anger, that's your work to do, not mine. And I think when we're talking about passive behaviors, and I say this in the most gentlest way I can, anger tends to be so dangerous. It isn't about just saying, okay, you have an anger problem. Anger management isn't about just saying anger is just one way. It's saying you have a problem. There's an injury. There's a something dysfunctional. There's something broken that doesn't work with your relationship with anger. And if we don't talk about it, it can't ever get better. Because then what we see are people who tend to live their lives of doormats. Like I'm just going to blend in, I'm not going to have an opinion, I'm not going to challenge, I just need to survive. Well, part of what we want to do is help people go from surviving to living to thriving, right? And if I can't express myself, if I can't have an opinion, then I can't grow because I'm constantly being suppressed for one reason or another. Does that answer your question, Mindy?
Yeah, I think it does. Thanks for that.
Sure.
Do
And
you
it's in
find
oh, sorry, Chuck, go ahead.
no, finish your thought.
Well, the one thing too with what I wanted to just say back to Mindy is any of these conversations aren't easy.
Well, yeah, yeah.
They're so painful. They were painful for me. They are painful for me. And I think we don't talk about it's painful to have an argument with someone. It's upsetting to have conflict. It's scary when I have to challenge someone. It's when I have to advocate when I feel that I'm wrong. It's hard to be wrong, right? That one of the one of the conversations that I love to have when I'm doing anger management is, what is your initial response when I tell you you are wrong?
It even gives me a twinge when you say it here.
Right,
And
right.
I'm like, I don't know, Patrick.
I
Don't like
don't know.
being wrong.
And that's what I love asking when I'm offering this course, is having that in a safe place of safe, secure place, hopefully, of just notice what you're noticing. Go with that. I'm not here to judge. I'm just here to present a question to say my physical reaction is going to tell me something more than if I can verbally process it.
Mm,
And honoring that there is pain here. When we're talking about anger, we're talking about pain. And if we can't address, that's why as clinicians, if we can't talk about that, we're limiting ourselves to how we can support our clients. It doesn't mean, and people always say, I hear the words, well, it's easy or hard. It's like, well, this isn't salsa. Like, I don't need to know what level of spice it is. Like, it's all valid, right? It's all valid because we have to grow and evolve in our own anger, and also being able to withstand other people's anger. It's not easy. It's painful. So I just kind of wanted to say that as well. Of anything that I'm talking about, isn't none of it's easy.
totally.
But that's why we
Yeah.
need the support to talk about, to normalize it more.
I hear, it's interesting, Patrick, thinking about, right? There's sort of like the therapist experience of anger and their relationship to anger. There's the client's experience of anger and their relationship to anger. How do you talk about sort of the stepping out into like the systems we live in, right? Because I think of anger in particular out of sort of all the emotions as being so incredibly racialized, so incredibly gendered in the ways that people are allowed to, right? What's seen as aggressive behavior or inappropriate
Right.
behavior is so dependent on the identities you hold. I'm curious, just like if that's something that you see coming up in sort of your clinical practice, right? Like equipping someone, the person in front of you inside a clinical setting, but then they step out into the world where they're, whatever identities they're holding, getting perhaps different messaging around like what is allowable.
Right. I think that's a really good question. I think that's part of your, if I was doing clinical work like phase one, where I'm doing the history intake, I want to know their
Mm,
culture. I want to know what their
yeah.
experiences are. And that means whether, and this is where I feel the field is lacking a little bit of what lessons have you learned about anger? If you're
Hmm.
angry, like let's go with the stereotypical one, like the angry black woman, right?
Right.
Or if a woman is angry, she's a bitch.
Right.
Sorry if we're not supposed to swear. And sorry, that just came
We're
out. But
fine. Well,
It
that
okay,
short now. We're good.
well, whoopsie, sorry. Better to ask permission
it's
than it is
Touchstone,
forgiveness or
Patrick.
whatever.
Yeah.
But I mean, but even so, that's what people are told, right? Oh,
Hmm.
you're on your hormones and all the nonsense, right? But then all of the stuff, and then when we're getting into like the deep rooted oppressive beliefs, that I think can really go into what is some of the work that we're doing with EMDR. How can we incorporate that into what target selection we are? And also being able to have that discussion of how do we want to talk about it in our relationship? Because I don't want to reinforce any of the abuse that person may have experienced. So I'm a white cisgendered male. I have to own that. Like, I used to teach gender and women's studies. In my first class, I'd be like, "So I'm gonna just name the elephant that I'm a white cisgendered male here, and we're gonna talk about that." If I don't, then I'm invalidating their experiences, right? And what I try to do as well is clarify if that's an issue for them or not. Because I also don't want to pigeonhole them of, oh, you belong in this group or you identify this way. That must mean you have an anger or you can't be angry. I don't want to do that. I don't want to re traumatize them. I want them to tell me their story. And then I want to clarify. Let's say we're talking about, dealing with anger or rage. Where does it come from? I ask the same question. I go, how did you learn how to deal with anger? Is this problematic for you? Does it affect your relationship? If it doesn't, we're going to move on. I'm not here to judge. I just want to know what we're dealing with. So that way, if your anger's kept you safe, if it's kept you alive, which in a lot of cases it has, fine. But I want to make sure that we're having the conversation, that it's something that's adapted, that's helping you, that's not depleting you. Because maybe there's another aspect or another resource or another support who can do the same thing that that anger is doing without leaving you depleted, and which can, in a lot of cases, lead to more anxiety, more depressive, more withdrawn type of symptomology.
Thank you. Yeah, I really appreciate that, right? The asking, which I think is something that clinicians miss all the time, sort of across identity base, right? I think that idea, like we know, right? If you have a woman in front of you, you know that she's been told that her anger isn't welcome, right? Making those assumptions, like
Right.
not not necessarily the experience of the person sitting in front of you, and B, like then I imagine you get people talking about like the nuance of the impact of that, right? Versus just assuming that baseline, you know, this is how you feel about anger because of the messaging I see people of your identity being told by, you know, our culture.
Right. Right. And just being human and not being afraid of not knowing their experience. I love that in grad school, that always stuck with me. The client is the expert on their life. It's like, I can know a lot of
Absolutely.
stuff, but tell me what it's like to walk in your shoes. I don't know. Even if, and I think sometimes, we're afraid to say that, even if we're similar or we appear similar, it doesn't matter because you're unique. And that is a beautiful experience. I'm humbled enough to be part of your journey, to hopefully help you get to where you want to go. If I don't understand all of the nuances, then I'm limiting what I can do to help you.
Mm.
And if people come in and they're angry about something, or something, if it's cultural or racial or gender, let's if they can't talk about it with me, that's a problem.
Right. And
And
connecting
one of
with
the things that
somebody.
we don't also talk. Right. Well, the other thing too, not just that, and this could be a whole other conversation, so stay tuned. There's still, I believe, an incredible amount of fear towards clinicians. And the reason I say that is because not only my experience, but other colleagues, we hear the question a lot of, do you think I'm crazy? Do you think I need medication? Should I be medicated? Am I nuts? Are you going to lock me up? Is this going to have some negative impact? There's so much fear. And it's based on our history, right? But we don't ever talk about it.
Mm.
We don't talk about, we try to be mindful in that differentiation of power, but that's the field that we're in, right? Like, if we don't talk about that fear and that worry and that anger, if someone's coming to me, especially if they're court ordered or something like that, if I meet their anger with defiance and resistance, then I'm just doing everything the system's done. I'm not
Absolutely.
seeing that it's okay that they're angry. I wouldn't want to be forced to go somewhere either. And I would see clinicians try to do that power thing of, well, you have to be here and I'm the clinician and I have the authority and blah blah blah. And as a new clinician, I remember saying to someone once, it just came out of my mouth. I said, yeah, I wouldn't want to be here either if I were you. I'm really sorry you're here. Like, how can I help you? They just looked at me like I had lobsters crawling in my ears.
How dare you be human?
Right.
But right, but then they looked at me, they're like, I'm sorry I yelled at you. I know you're not the one who sent me here. He said, let's figure out what we can do to get you out of here. In the best way, whether if it's treatment or a port, like, let me just kind of help you. Um, but if I had just stayed on the anger, I would have lost that connection.
Absolutely. Yeah. No, thank you. I appreciate that nuance. I think, right. And that sort of making the implicit explicit, right? The things that you're thinking about and your client is thinking about and the fear they might have about you, like putting it on the table just allows for it to be addressed in such a different way and stops it from just being sort of like diffused into everything happening in a clinical
Right.
setting.
I mean, there are days where I feel like Wreck-It Ralph, right? Like I have a big heart and I just feel like everything because I'm human, right? Or, I think we have those feelings. And, when we're angry, it's also, it's okay to be sad. It's okay to have these feelings of, I know someone gave this analogy once and it just stuck with me of, when a painter goes to work, they expect to get paint on them. And I think as mental health clinicians, we forget that when we're going into the mental health field, we're going to get the mental health stuff on us.
Mm.
And it's easy to get burnt out. It's easy to get exhausted. It's easy to get frustrated and to lose hope. And if we don't have an open, ongoing conversation, we're going to be burnt out and we're not going to be able to help the people that we love. And we're all, it's part of that cycle. And then because we're so afraid to talk about it, to say I'm angry or I feel hurt or I feel whatever I'm feeling, then we're doing a disservice to ourselves and to our people.
Absolutely.
That. I feel like we've talked a lot about like these really core foundational pieces of like validating the person in front of you, right? Addressing your own fear around anger, addressing your, client's fear around their own anger. Do you have sort of on the like clinical end of things, like assessments you recommend to people or different tools to sort of like get a better sense of like the profile of anger that they're addressing?
Yeah, and I go over that in the course just because I don't have all the names, everything in front of me. I don't want to.
Totally.
There are some great assessments out there. People have done some amazing, beautiful work, and I spend quite a bit of time in the course going over that with the resources that really can lay it out A to Z of really if you're dealing with someone. A lot of the anger management stuff that you see is geared to group, but I talk about how to tweak that a bit to make it individual or for couples as well to be able to incorporate that into your practice. But there's some great resources out there. Some, and some are free and some are more of an investment, but absolutely. And what I also wanted to say for this course that's coming up is even though it's focusing on perinatal, right? So I think of parents who are going through traumatic experiences, loss, or different issues with conception, or dealing with hospitals, or all of the things. You don't have to specialize in perinatal mental health to benefit from this course. I've always hated when you go to a course and it's just like this little one tiny piece of the pie. I try to make it versatile so everyone who comes can improve their practice. That's my goal as an educator, to be able to say, yes, we're talking about perinatal for this. It's an important part of this, but how can you incorporate this into other aspects? Like every person usually works with one person who's a tired parent. Mom guilt,
Mhm.
parent guilt, all of the different things, single parenting, all of the spectrum that we all hear, and being
Mhm.
able to have an amazing toolbox that will help your clients be able to breathe a bit until they can get to that next session, until they can handle that a little bit better, so they can handle that next doctor's appointment, they can handle the next exam, they can handle, one of the things that I always see, um, that's hard is I kind of call it the drive-by trigger moments when you're doing well, but then you walk into a store and it's Mother's Day and you see
Mm-hmm.
all the stuff, or Father's Day, you see all the stuff, or you live by a school and that's a daily reminder. Being able to give those people tools that they can breathe through those moments of excruciating pain is invaluable.
Mm.
It's life changing because we want them to be able to talk about their grief, talk about their loss, their anger, and also to be able to breathe and know that they're going to be able the life's not going to be the same, but they can redefine their mental health
Mm.
and their emotional well-being.
Mm. Thank you for that, Patrick. Wendy, I feel like you had such a good question for Patrick about the perinatal piece before we
Right?
went live. Do you remember it? I can work my way through it if you don't remember, but it was a really good one.
Oh, well, I think we covered a little bit of it. But yeah, I was just curious about differences in how um how you see birthing parents versus non-birthing parents experience anger, and how that's perceived, either in a clinical setting or just out in the wild, and
Mm.
how that how that differs. Because I know, just I'm just thinking, like, there's so many instances where, when you're talking about like mom guilt and everything, like if it's the birthing parent who is struggling versus the other parent, like, sorry, I'm not being very articulate about it, but I'm thinking about, like, from my own childhood, like, wait till your father gets home and that
Oh,
kind of
right.
stuff.
Mm.
And so how you see that, playing out, and and what you do with it.
Well,
Mm.
I think I'm very honest and genuine with people. I'm not a parent. And if people ask that, I'm happy to say that. It's like, no, no, if you want to talk to someone who is, we can work that out, or we can talk about that. I think it's important that people are able to identify what their needs are. Some people might want to speak to a female identified therapist, or they're okay with talking to a man. I one of the I, Being able to look at what are the spectrum of issues, how do we normalize what they go through, and the frustrations and the stress, and then being able to incorporate an approach that's going to help them individually. So, for example, I work with a non-for-profit organization here in my area, of perinatal focus, and we created a group for male identifying clients. Uh, we call it like the fathers group at that time, but it's open to anyone. Of I don't want to talk about it, support group,
Mhm.
right? Because you have one partner who wants to talk about it all the time or needs to talk about it, and then you have a partner who never wants to talk about it again. And I think that's where you really want to work with a multifaceted team, if you can, of being able to say, are we doing individual therapy? Because we might need that for both partners. And then, if and when it's appropriate, do we need couples therapy, or do we need some sort of couple support? And part of the when I became a life coach, and being able to offer that, I wanted to offer something as an educational program for partners who may not need or want therapy, but want some skills to improve their relationship, and being able to create that to focus on people with perinatal loss, or perinatal trauma, right? To be able to say, these are our issues. How do we, when we're speaking, once again, it's speaking different languages, it's dealing with grief, different languages, different approaches. How do we create a common language so we don't lose each other? And the biggest thing that I try to do is just validate. Like, this is my own little soapbox. Like, I get very protective and angry about the mom guilt, because these parents are killing themselves, and they're doing amazing jobs, and then they get an online comment, or they get some stupid thing, and it's like, working with adults, it's not about the Tupperware. When you hear about trauma, it's, you're there, you're doing the parent work, you did the birthing, you did the supportive thing. We want to really encourage that, because the external world, like you said, out in the wild, is vicious.
Hmm.
And most of us, I think, rely a lot on social media and social connection, but there's no filter there. And I think when we're looking in the therapeutic work and the support, I try to really acknowledge that and see what they're looking for, and is that need being filled for something nutritious, adaptive, and healthy.
Mm.
Because if they're and that even means, like, are they relying on a family member who's telling them everything they're doing is wrong?
Sure.
I want to have those conversations, as part of the intake, and developing a relationship of, where are you getting your support? How are you filling your cup again? Are you going into these doctor's offices alone? Is your partner? Do you not have a partner? Are you not able to go with your partner? Do we need to get you an advocate? Let's see what resources we have to make this less traumatic.
Mm.
Is that helpful? Does that answer your question, Mindy?
Yeah, I think it does. Thanks for that, Patrick.
Sure.
Patrick, we are just about out of time, and I'm wondering if there's anything, you want to share more about your course in October. Mindy will get the link, the link's in there, and your website link is there as well. And B, if there's just if there's one thing that someone's going to walk away from this hour, I think specifically as a clinician to know about anger or sort of the things to explore around anger.
Absolutely. So the course is coming up in April or October. I keep wanting to say April. Maybe I'm looking for. I'm not ready for winter. I'm really
Not,
anxious.
skipping to
Do it again
spring.
in April.
I just dissociate on it because I'm not ready. On October 4th, it's really a packed class. You'll hopefully walk away with it feeling fulfilled and having some guidance on yourself and how to help your clients and incorporate the skills that you already have, because we don't want to reinvent the wheel. Being able to see what you're doing, what's working and what's not working, and how it can support you to create a program that's more efficient for you and your clients. So that is really exciting. We'll also, if you follow me on social media and on the website and everything, I'm going to be offering a Hold Me Tight in the fall, and that's for couples. And the way I do that, I do it all online, so you can do it in the comfort of your home. You don't have to use cameras or anything like that. It's just me, like a class, which is really nice for couples who don't necessarily want to go somewhere or want their privacy exposed to other people. It's a great way to be able to focus on your relationship, whatever level of relationship you're doing. So stay tuned for that. And I would say one of the questions that I would suggest that you walk away with is, how do you handle anger as an individual and as a professional? And just kind of notice what you notice and go with that.
And go with that. Well, thank you, Patrick. This has been, so helpful, and I so appreciate you, addressing this topic, because again, I think it's one that is so rarely talked about above the surface, and it's relevant to any client you could possibly have. So we are very excited to have your course happen in October and to have you on our team.
Thank you.
And
Well, thank you so much for inviting me. I appreciate it.
absolutely. And thanks for taking the time today to give people a little sneak peek of what's to come.
Anytime.
Absolutely. All right. Thanks, folks.